Tonight we're going to talk about fibromyalgia, and the title also says what we all can do about it, but in the end I'm going to try to impress upon you how much you can do about it. Fibromyalgia was described using ARA criteria back in 1990 as a widespread pain problem affecting three areas of the body: the spine, above the belt, and below the belt on either side of the midline. It is not arthritis. It has not been documented to be physically disabling, and there are no diagnostic tests. In the beginning, we used tender points to help describe fibromyalgia. You had to have 11 out of 18 tender points positive, and you had to push with 4 kilograms of pressure using the flat part of your thumb. This was not impossible to do, but required a standardization that most people really didn't pay attention to. Disagreement, and impaired memory, or what became known as fibrofog. Using that definition from 1990, about 7 to 10 million Americans were identified with fibromyalgia, resulting in about 2 to 4% of the entire population of adults in this country being diagnosed with fibromyalgia. But surveys of the community found that anywhere from 10 to 13% of all adults live with chronic widespread pain at least several days a month. The median age of diagnosis was between 29 and 37, and females outnumber males 7 to 1. It's a fair amount of what gets referred back to rheumatology, and about 25% of people who have been labeled with fibromyalgia are currently receiving disability payments. We can see that fibromyalgia actually increases in prevalence up to around 8 to 10% of the female population by the time they reach age 65. And there seems to be a familial aggregation of fibromyalgia, and the relative risk of having fibromyalgia, if it's in a first-degree relative, is 8 times what the normal population risk is. There's decreased pain pressure thresholds, in other words, decreased pain resistance in relatives of people who have fibromyalgia, and there appears to be a genetic basis. In a study looking at chronic fatigue and fibromyalgia, they found 3 single nucleotide polymorphisms, or genetic alterations, that were very frequently found together in patients who had chronic fatigue and fibromyalgia, and all of these turned out to influence chemical messengers of pain to our consciousness. We know that the appreciation of pain in patients with fibromyalgia is different than in normal. While they may have normal thresholds for sensing colds, heat, and pressure, patients with fibromyalgia have lower thresholds when those stimuli become painful. They have higher levels of substance P, which is the common denominator, or in the pathway of pain being registered in our consciousness. Substance P is a very important part of that in our brain, and there's higher levels of that in spinal fluid of patients with fibromyalgia. And we can demonstrate that there's a change in how the brain metabolizes by measuring brain blood flow. And there's different areas that are lighting up with pain experiences in normal patients versus those with fibromyalgia. And we can see that chemical messengers like serotonin levels are lower, and there's changes in those receptors and transport genes, as we talked about. And there's even a change in how a fibromyalgia patient's body handles stress, including changes in their cortisol levels, which is the stress hormone. All of this combined seems to represent an alteration in the central nervous system, a hypersensitivity, if you will. And so the term central nervous system hypersensitivity syndrome has been coined to explain this. If we look at pain and characterize it as a pain that just begins or is acute, or a pain that's been present for a long time and is chronic, we see that there's a spectrum of pain from an acute injury to those patients who have chronic pain from diabetic neuropathy, or from temporal mandibular joint disease, or chronic daily headaches. And as a patient has more and more chronic pain, we find that much more of the features of central nervous system hypersensitivity is invoked. And while there's probably a spectrum between the acute and chronic for almost all pain presentations, This is a concept now that can be useful to look at how people are going to respond to pain interventions. What can cause central nervous system hypersensitivity? Well, people have always focused on the non-restorative sleep of patients with fibromyalgia, but physical deconditioning and inability to stand for long periods of time, stressful triggers, whether it be a viral illness or some sort of post-traumatic stress, all can contribute to hypersensitivity of the central nervous system. Psychological trauma or abuse, from a physical or a psychological perspective, I think can sensitize the central nervous system. But after 28 years of doing this, I'm convinced that issues like poverty, chronic unhappiness, and patients that are focused on a loss of control of those around them can also increase hypersensitivity of the central nervous system. The pathogenesis of fibromyalgia then focuses on neurotransmitters and chemical imbalances that contribute to that central nervous system hypersensitivity. And here on the left we see a graph looking at the amount of substance P in the cerebral spinal fluid. And note that it is substantially higher than those controls without fibromyalgia. And when we look at blood-brain flow diagrams using MRI and cerebral flow superimposed, we see that those patients with fibromyalgia experiencing the same stimulus as a normal control have different parts of their brain become more metabolized, having more metabolism. Nowadays, instead of the 11 out of 18 tender points with the fibromyalgia diagnostic criteria, we have a focus on what's called the polysymptomatic distress scale, in which a survey looks at painful areas over the last week. And there are 19 different areas, and the patient is asked to circle the areas that have been hurting in the last week. You notice that these are not joint areas necessarily. And then they're also asked to rate how much fatigue, inability to wake with your batteries charged, and cognitive compromise affects daily life. Together, if you were to score everything on this, you would have a total of 33 points. But any score above 13 is considered to be indicative of fibromyalgia. But when we've looked at folks, it's not just an on or off phenomenon. And the previous ACR or ARA criteria described it as a very discrete illness with tender points and psychological factors and behavioral maladaptation. But now we're more focused on this idea of a continuum where people can have a little bit or a lot of fibromyalgia depending on how much central nervous system hypersensitivity is involved. And this is this chronic pain continuum that we talked about, where there is a transition from the acute pain to the chronic pain and a change in how the central nervous system is involved in processing that. And while fatigue and diffuse tenderness are very prominent, psychological factors and negative pain behaviors and maladaptive behaviors really only play a role in a few individuals. And when we look at this concept of fibromyalgia, just the amount of widespread achiness along with fatigue and cognitive dissonance and poor sleep, we find that you can apply this same concept to a whole host of chronic illness behaviors and symptoms that present to the primary care provider, including fibromyalgia, fatigue, daily headaches, temporomandibular joint dysfunction, bowel irritability, chronic acid reflux-like symptoms, post-traumatic stress disorder, female urethral syndrome and interstitial cystitis, restless legs, myofascial pain, and even Gulf War syndrome to a certain extent represent a common pathway of central nervous system hypersensitivity. It's been estimated that with this sort of definition, about a third of all the public has chronic pain, and about 50% of all primary care visits are really related to the amount of central nervous system hypersensitivity. Although the focus might be on acid reflux or a headache, the patient would probably benefit from a step back and to look at what sort of factors might influence that hypersensitivity in general. So here is another way to look at that pain centralization continuum from acute pain, like cutting yourself with a knife or getting burned on a hot plate, to a more centralized issue with fibromyalgia, chronic fatigue, daily headaches, and things like that. And the clue to whether a person has significant central nervous system hypersensitivity is what I consider the triad of chronic pain. Obvious evidence of suffering with their pain, sleeplessness, and sadness. And when you combine those three things together, and I see that, I'm always thinking that part of their problem, whether it's rheumatoid arthritis, back pain, or fibromyalgia, really is that central nervous system hypersensitivity. It's interesting that with chronic low back pain, the first thought is, what does it look like? What do the x-rays show? What are the MRIs showing? But the Boeing study that looked at 22,000 employees and looked at all their x-rays of their back could not identify a marker on x-rays of the back that would identify a group of people that were more likely to get back pain in the future. And it's been shown more recently by Dan Claw that just pressing on the thumb to the point of pain is a better predictor of low back pain and functional status than getting an MRI of the lumbar spine. And it turns out that people with back pain have functional MRIs showing those same kinds of changes in blood flow patterns to different parts of the brain that we see in fibromyalgia patients. So there's a lot of evidence for a generalized lowering of the pain threshold and a change in how we process pain and fatigue stimuli from our body to our consciousness that seems to drive the issues of chronic pain and fibromyalgia. We should look at this as a volume control of pain centralization. Not everyone's turned all the way up to max, and not everybody is down at the minimum level. Most everyone's somewhere in. And here is a great study back in 2013 that looked at measuring all people who came into the hospital with total knee and total hip arthroplasty. And as you can see, most people really score on the polysymptomatic distress scale below the level of fibromyalgia. However, there's obviously a spectrum from some people who score 1 or 2 points and others who score 10 or 11 points. And while they wouldn't be labeled as having fibromyalgia, for every pain higher on the fibromyalgia or polysymptomatic distress scale, they required 9 milligrams more of morphine for post-operative pain control. And they were, for every point higher than the other, they were 20% less likely to reach 50% improvement in pain after arthroplasty at 6 months. So you can predict the outcomes of how their person is going to do with a total hip or total knee arthroplasty, both short-term and long-term, by just simply measuring their polysymptomatic distress scale. Now, in the past, we've pretty much thrown a gamish of things at people who have chronic pain, including steroids and non-steroidal anti-inflammatory drugs like ibuprofen. Some people have used extra thyroid to improve energy, vitamins and elimination diets, and proprietary nutraceuticals, all based on some sort of empiric belief or thought that there may be some sort of a deficit here that needs to be replaced. But we could base our treatment on this concept of central nervous system sensitization, and it's turning out that that's a more effective approach to managing the issues related to chronic pain. And so using a multimodal approach right from the beginning, medications to reduce the pain sensations from where they start in our peripheral skeleton, in our joints, in our muscle attachments, with drugs like non-steroidal anti-inflammatory drugs or tramadol, to using more centrally acting medications like anticonvulsants, like anti-seizure drugs that work on chemical messengers, and antidepressants that work on chemical messengers, but also focusing on keeping stimuli in our environment from ever irritating and causing the pain to begin with. So focusing on adaptive aids and heat and ice and massage, proper surfaces for sleeping, and focus on both therapeutic and conditioning exercise. Behavioral modifications, because we can actually retrain the brain and reduce that hypersensitivity by using meditation or yoga or controlled breathing exercises, Pilates or Tai Chi. And eating right. I think it's important that we have a balanced diet and that we focus on weight management. And occasionally tender point injections, when they are the most prominent aspect, the tender point is the most prominent aspect of a patient's presentation, can also be very helpful. But they shouldn't be focused on as an ongoing way of managing the issues of fibromyalgia. And it's important to emphasize to everyone that drug treatments of fibromyalgia just don't work by themselves. The patient must apply the lessons of wellness and healthy living, really make a commitment to healthy living. Otherwise, they're going to really be doomed to continuing the issues of widespread pain and fatigue. So, from the standpoint of preventing the pain stimulus from ever occurring in our peripheral skeleton, pacing our activity, and I say staying within the bounds of the energy envelope that your body currently resides. A lot of people will push themselves to the point of physical or emotional exhaustion, and then they pay for it with increased pain and fatigue. But if they recognize their boundaries and try to maintain in that envelope of comfort, they do much better. It's our goal to make that envelope larger over time, and that might include both mental and physical exercise so that we are more resistant and have more resilience with everyday life, and so that energy envelope increases in size. But that takes a long time, and the patient has to have patience to get to that point. And this includes things like posture exercises, conditioning exercise, weight management, and dietary modification, so you're eating well and not stressing your body. It includes focusing on modalities such as heat or ice, or just having to take a hot shower more often during the day with flares of widespread pain. Adaptive aids like mattress pads 2 to 3 inches thick with medium density foam that's temperature sensitive can be a marvelous approach to keeping your body from getting irritated overnight. And proper footwear, I can't emphasize enough, spending the money so that you get shoes that fit you and keep your foot and ankles aligned. Improved interpersonal relationships can also make a huge difference. And I think this is where concepts like meditation and learning to avoid regretting the past or fearing the future can be a very important part of the management of your fibromyalgia. And we can also blunt the pain stimulus that's occurring at the joint or at a tender point with drugs like ibuprofen, tender point injections, counter-irritant creams like aspirin with lidocaine, and topical anesthetics like biofreeze or topical lidocaine or spray and stretch type approaches with ethyl chloride spray. Good nutrition is important, whether it's vitamin D, calcium, magnesium, the right amount of fatty acids, or avoiding oxidant type things. I think is probably open to debate. I think eating right and eating sensibly is all we really need to do. Most of the nutraceutical, I think, are oversold. Getting a better night's sleep is critical, and people always think they need a pill to help them sleep better. But I think we could look at Michael Jackson as an example of how you can look and look and look, but you're not going to find a drug that's safe and effective to help you sleep. In fact, we know now that cognitive behavioral therapy approaches to sleep management work substantially better than medications over the long haul. Opiates should be limited to tramadol because higher dose opiates and stronger opiates have not been shown to be helpful for chronic pain, and they really don't influence central nervous system hypersensitivity. In fact, there's great concern that analgesic withdrawal and hyperanalgesic rebound occurs after the medication wears off. And these drugs are frequently short-acting drugs like hydrocodone, only lasting 2 to 3 hours, and you may have more pain 3 hours after you've taken the drug than you started with. TENS units are helpful in some, and there's great interest in vagal nerve pacemaking, and I think we're going to see more about that in the future, although that's clinically available at this time. We can use medications, but we can also use changes in lifestyle and active exercise-like approaches to stabilizing our neurons and to decrease central nervous system activation. That includes things like meditation, just learning more about your condition and what you can do about it, and having fun. It's amazing how much less pain you have if you watch a funny movie. Anticonvulsants have been used now to help manipulate those chemical messengers, both in the central nervous system and as they send messages to the central nervous system from our arms and legs and other parts of our body. The drugs that are used most often include gabapentin and pregabalin or Lyrica, but other drugs have also been used with some success. NMDA inhibitors are, in my opinion, a disappointment. Dextromethorphan had really no effect on fibromyalgia, but tricyclic antidepressants and tramadol have some effect on these NMDA receptors, and these work by reducing what we call wind-up, or the enhanced neurologic sensitivity that occurs after repeated painful stimuli. TENS units in acupuncture also can be helpful in stabilizing our peripheral nervous system. What about our central nervous system? Well, exercise and better sleep are probably the most important approaches to reestablishing the balance and reducing that hypersensitivity in the brain. But other medications, like some of the antidepressants that affect norepinephrine and serotonin, have been shown to be helpful. Anti-anxiety therapy has its role, especially in people where that is a dominant problem. There are medications that affect muscle relaxation and muscle hyperactivity, using drugs that are frequently used to treat Parkinson's disease with the extra motor sort of hyperkinesis that you see with the tremors of people with Parkinson's disease. So drugs like Mirapex and Sinemet and Requip have been used in fibromyalgia, but with minimal benefit. And then you can modify the chemical signature of pain that goes to our consciousness with drugs like tramadol, but we want to avoid stronger opiates because they haven't been shown to be beneficial long-term in chronic pain, and there's the issues of hyperalgesic rebound. So we talk about a whole host of treatment options in the pharmaceutical arena, and it includes things that I just mentioned, but there's also things out there that are being tested and looked at, like marijuana, and more potent medications that work on the central nervous system. But I found that many people do not tolerate these medications because they're basically sensitive to everything. They're sensitive to the firmness of the mattress, how often they're standing or sitting during the day, how stressed they are, or what is the level of their bank balance, and they're sensitive to the medications that we give them. So I like to look at the multimodal approach with some medications, some and probably increasing emphasis on the wellness aspects that include using adaptive aids and modalities like massage, ice, and heat, behavioral modifications, and modification of our thoughts using meditation and controlled breathing exercises, eating right, losing weight, and I think this is most important. Now, this was a summary of the diagnosis and management of fibromyalgia in a recent article by Dan Claw that was published in the arthritis literature, and it shows exactly the same concept: is working on sleep problems, increased physical activity, a focus on rehabilitation, adaptive aids, and then also medications, but starting with the simple and really recognizing that these drugs have a limited effectiveness, particularly on their own. Here was a study looking at tramadol with Tylenol in a patient population with fibromyalgia, and there were several areas where there was a significant improvement in pain and physical impairment with the use of tramadol and Tylenol versus placebo. And let me just show you under the pain score that was done that the patients with tramadol versus placebo had a drop in their pain score from 7.2 to 5.7 versus 7.2 to 6.4. And I'm not convinced that you could really distinguish on a given day-to-day basis that your pain score had fallen from 6.4 to 5.7. Now, individual patients had some improvement, but overall, if one looked at the improvement, it's a very small improvement, and the people were still substantially in pain with a pain score of 5.7 out of 10. So not a home run. And neither is a treatment like Cymbalta or duloxetine. They're the same drug. That's duloxetine. It's just the generic name of it. This was a 12-week study looking at 207 patients with fibromyalgia. And if we look at just the pain scores and the fibromyalgia impact questionnaire, they couldn't show any difference between the highest dose of duloxetine and placebo. But if we looked at the entire fibromyalgia impact questionnaire, which has 80 points, the average patient on the active drug, or duloxetine, had a drop in their score by about 5.5 points. That doesn't suggest a dramatic improvement, but it does suggest mild improvement with medication. And it turns out that that improvement was not related to being depressed. That didn't influence at all whether these people got better or not. And let's look at gabapentin, another 12-week study using the primary outcome of improvement by 30% in their brief pain inventory score. And compared to placebo, 51% of the people had an improvement of 30% in their pain score, and 30% had an improvement in their pain score if they were on placebo. Not a huge difference. And the average improvement was 1 point on a 10-point scale. So again, the improvement is modest. Unless you're journaling and writing down your pain scores over a period of weeks and months, you might not even appreciate that the drug is helping on a day-to-day basis. What about Lyrica? And this was a study of over 500 patients, 8 weeks. And one of the things that was nice about this study is they showed that improvement really occurs quickly within the first week once the dose has been ratcheted up to the highest dose. And what they looked is the 30% improvement level again, and 48% of the people on gabapentin showed a 30% improvement in pain, which is impressive, but they were just only twice as likely to show that improvement as someone who was on a sugar pill. And if we look at a 50% improvement in pain, which is what a lot of people might say they really think they should have to make a drug this expensive worth it, only a third of the people had a 50% improvement in their pain scores. They did have less fatigue and better sleep, but 12% complained of dizziness, sleeplessness, sleepiness, or weight gain. And weight gain has been a big problem along with water retention in the patient population with this drug. And we have to be concerned when we start using multiple medications that can affect the chemical messengers in the brain, because we can trigger a rare but still very serious problem of what's called serotonin syndrome, where there's a sudden huge release of serotonin, resulting in dizziness and euphoria and confusion, severe headaches, sweating, shivering, high blood pressure, and even seizures. I've had patients where they've had to be hospitalized because of the buildup of serotonin. And so you have to be on the lookout for the early warning signs of that condition. In summary, these medications are helping a minority of those who take them, and they don't seem to work extremely well. And a lot of that is because patients who are placed on these medicines still haven't bought into the concept that they have a major role to play in the management of chronic pain and fatigue. They aren't following those wellness-based techniques. And we focus too much at this point on polypharmacy. And we really don't recognize how important it is for the patient to make the commitment to a change in lifestyle. Now, who should be treating fibromyalgia? Remember, rheumatologists are trained to be clinical immunologists and inflammatory doctors. We don't have any training, at least until very recently, in issues of pain management. And in fact, nobody has huge amount of pain management skills unless they went into pain management until the last couple of years, where training programs for most specialties are starting to recognize how important this is. But there's only 5,000 practicing rheumatologists in the United States. And for the most part, with so much of primary care being related to central nervous system hypersensitivity, I think we have to rely on our primary care colleagues to do the bulk of the work of evaluating and managing with chronic pain. But I'd like to point out again that I think about 80% of the pain management is really up to the patient themselves. And I would like to refer you to this website, which has a very interactive web experience looking at 10 different areas of chronic behavioral therapy and understanding fibromyalgia, improving sleep, being active, recognizing the importance of muscle relaxation, and setting off some time for yourself, setting goals that are reasonable to improve that energy envelope and to reduce the stress that keeps you from sleeping at night, pacing yourself, and learning to think differently, be able to communicate your distress with your loved ones without sounding like a broken record, and how to cope better with the problems of cognitive dissonance or fibro fog that occurs with chronic pain and non-restorative sleep. And you would think, why would I want to do something like this? Well, a study looked at 118 fibromyalgia patients that were introduced to the website versus just put on medications. And if you look at that 30% pain improvement score, notice that of the group that were just given the website in addition to usual care, 29% had a 30% reduction in pain. That was versus 8% that were given just usual therapy. That's a big difference, and in fact, a bigger difference than any medication we looked at. So I think it's really important that the patient recognizes it's their problem to wrestle with, really. Your goal is to stay functional. There is no promise of a pain-free existence, and no drug will solve it. No doctor will make it go away. You have to manage your own fibromyalgia. To a certain extent, it's the same problem as if you had diabetes. It's not just insulin or a pill. You have to eat right, you have to exercise, you have to pace yourself. And I think it's the same concept. Sticking your head in the sand and assuming that someone else will solve your problem will not make it better. You have to, if you take medications, accept some side effects for improved pain control. Potentially, the issues of fatigue or even weight gain are there. Be prepared to pay for these medicines out of pocket because the FDA, while they may have approved a drug like gabapentin or pregabalin or Lyrica, your insurance company frequently, if not most of the time, won't pay for it. And then plan on making lifestyle and interpersonal relationship changes to enhance and protect your wellness-based lifestyle. I think that's critical. And I hope that with this kind of guideline and some of the resources we've talked about today, you can make fibromyalgia a smaller part of your life. Thank you.